All right, so thanks everybody for coming, you guys. This is the first roundtable of 2022, so thanks for joining us. We've got an excellent lineup of presentations for you guys. Next up, we have Rita Dekleer, who's going to talk to us about IPAC.
Yes, my name is Rita Dekleer. I'm one of the infection control practitioners here at Vancouver General, part of Vancouver Coastal Health Authority. And I feel quite honored and privileged to speak to you and slightly nervous, so don't mind me. But so Alana and I talked about what would be interesting to share, and we thought we'll talk a bit about behind the scenes with IPAC and my role with supporting the ICU during COVID-19. I'm not going to be going into statistics or numbers or anything like that. I feel I'm giving a little bit more about the personal side as an infection control practitioner working through this pandemic. So we'll see if it all makes sense. Okay, so a land acknowledgement has been given already, so I won't repeat it, but as we know, we're gathered on these territories. And I know this is a busy slide, what you're not supposed to do, but I don't think you're all that much interested, but really what is the role of an infection control practitioner? And I think, you know, it's a very, I'm fortunate, I love my job, I've been doing it quite a few years. So it's everything from development or implementation or education about everything that affects the hospital, affects the hospital in regards to the prevention of infections. My competencies have to be in everything from infectious diseases processes, laboratory microbiology, talking about routine practices, a bit of epidemiology thrown in there, and trying to do some research and education. A big part of my role is surveillance of healthcare, transmission of infections. So you've all heard about antibiotic-resistant organisms, focus on surgical site infections, and of course, hand hygiene. I have an interesting career because I get to consult on everything from cleaning and disinfection and sterilization to what are we using to mop the floors to, of course, outbreak management. And, you know, pre-COVID, it was things like Norwalk and influenza. We do a certain amount to do with pre-purchasing evaluation. A large part of my role here at VGH is embedding infection control into construction, renovation, and maintenance activities. So things like when ICU renovated their burn shower room to actually become a patient care room, how do we make sure that there's sinks? What is the ventilation going in there? What's the plan for soiled equipment? We dabble in a bit of occupational health and safety, but really for staff, that's all people safe or occupational health and safety, whatever you call them. My favorite part of the job is doing education and planning for emerging infectious diseases. Little did I know that would include a pandemic. And then we do fall under the realm of quality and safety. And, you know, we're fortunate that Vancouver Coastal is committed to a lot of great research to do with infection control. So, but the daily bread and butter of any infection control nurse, now for me, ICU is just one of the areas I'm responsible for. So I do daily rounds looking at ICU patient census. I review all the microbiology reports, trying to figure out who needs isolation, or as I prefer to call myself, a de-isolation nurse, trying to get people off precautions. Definitely involved in quality improvement projects. Again, that cleaning and disinfection, which is, you know, when the ICU doc says he wants to bring in this new piece of equipment and they can get it donated for free, and I say, yeah, and how are you going to clean and disinfect it? And they say, oh, we'll just wipe it with some soap and water, and then I get to be the nag and say, well, maybe we should look at whether this is low, medium, or high disinfection processes, things like that. Surveillance of healthcare infection. So I long for the days where all we talked about was MRSA or C. diff. And then certainly, you know, I've been best friends with our local public health staff for all this reporting of communicable diseases. So whether that's invasive group A streptococcus or measles or what have you, and certainly the last couple of years, COVID. So I'd like to bring us back to early 2020. And I must say already in December 2019, over Christmas, we started hearing about something going on in China. And we didn't really know, but we knew, and honestly, some of the ways we were hearing was our Chinese nurses who read both Chinese and English newspapers were saying, there's some infection starting in China, and we, you know, trying to get information was very dicey. So that was Christmas. And I know in January, I said to my boss, Dr. Titus Wong, I said, what is this? Is this going to be something or not? And at the end of January, we did our first, and I just checked, it was about January 19th, 2020, like how would we even answer questions about whatever this was? So, a bit of a patient case report form, and we started an Excel spreadsheet, and we didn't even really have a title for it. We really did not know what we were talking about, except there was some sort of infectious disease thing going on, could go global, could come to Canada. Oh, that was pretty vague for all of us. And then if you think back to some of the early jokes, now I must say, I do love, when I go back, there's been so many great jokes. So at the beginning, it was, somebody like me, because of age, I could say, remember SARS, what we went through with SARS and what went on in Ontario? But a lot of our younger nurses were like, SARS, what was that, right? Because that was like the 1980s. And then we sort of progressed with some of the jokes, like really, and I remember people ask, are we really going to start masking? And I was like, oh no. And are we going to start wearing cloth masks? Oh no. Because there was just all sorts of crazy ideas being thrown out. And, some great cartoons then. Turning around, the beauty with my relationship with ICU is because I've done those daily rounds for probably about 8 years, I think I've been covering ICU, is I really had first-hand experience with the team. I'm privileged that I get to sit on their quality improvement council or whatever you call it. So I've seen all sorts of things go through that show this great, dedicated team, amazing teamwork. I'm just bragging about them for a moment. They're always doing new things. They're compassionate. I was involved a bit with the wishing, did we call it the wishing well? Wasn't the wishing well, but, doing courageous things for end-of-life care. They're always teaching something. There's always new machines going on. And so, I feel very fortunate to be part of such a wonderful team. So when it came down to, what's coming? And you can see me in the red sweater there, and I have to thank Tammy for these pictures. So Jackson, you can see Jackson right behind me. We would start these huddles, and I only stood there with a piece of paper. Like, we didn't have a coronavirus website. I just kept saying, go to the IPAC manual. Here it is online. Download it on your phone. We'll do airborne contact precautions. And I think the biggest thing, and I really have to thank the ICU team, we stood there and we just kept saying everything honestly. There was no hidden agenda. It was like, this is what we know today. It may change tomorrow. It may change next week. But as of this moment at 3 o'clock, this is the story that we know. And so, Tammy, thank you for those pictures, because it also shows, how many people would gather around me. And I'm confident, but I was pretty nervous then. And I talk about honesty, but we really didn't know what was going on. And it was very nerve-wracking days. And I think around the same time, I'm going to digress a moment. So we're talking March. Now, the first outbreak in Canada was in the long-term care facility, Lynn Valley on the North Shore. So for us, the alarms were ringing. We ended up with the first, I think, death in Canada there. And that was like, so whereas other provinces even had a month or two, we were like, it has landed. There's so much that goes on behind the scenes with infection control. And for me, part of my responsibility was ICU. But at the same time, I'm being asked to go to these other outbreak facilities for long-term care and try and teach infection control on the run there. Because, I think with COVID too, at the beginning, we thought, it's going to be the whole downtown east side that goes down. And then it started, sadly, in all our other long-term care facilities. So, we were being very honest, and I think probably that's what helped with being transparent, that, okay, I want to help ICU, but really I have to go to the Sunshine Village, and if we can keep the Sunshine Village COVID-free, you're going to get less hospitalizations. It was those early days, oh my goodness, I can't say enough. Come on. What we were hearing from our international colleagues was, and it's, it sounds like a simple expression, but go hard. And because it was very hard to know, which should our focus be. And so what we were hearing from Spain and France and Italy was, and trying to tease out the information from our colleagues around the world was, how hard do you go? So Thank goodness Vancouver Coast, well, the province, I have to attribute it to the province. The Ministry of Health a few years ago had said every hospital has to have some sort of teaching and program for an all hazards approach. And that was because if you think about 6-7 years ago, we had the issue with Ebola in Northern Africa. And that was a real sort of twitchy point for us in infection control too, if this was going to become a global pandemic. So thank goodness ICU had done a lot of the all hazards approach, Ebola prep. So some of the language was already there, some of the background, you know, what you could use for signage or planning. And at the very beginning then, that March time, it was like, okay, every time we'd have a decision, I'd say, they told us to go hard. So we developed these phenomenal COVID units, which engaged, you know, we had project managers, we had HVAC engineers, we had the nurses who would be working in it. There was just a real commitment in both Vancouver Coastal Health to let's start building, even if it's temporary. Better to go hard, build lots, than later try and start building and designing. So I wish I remembered the date, but our poor CSICU within like 48 hours notice was kicked out of CSICU, and we built the first COVID unit, which was built along the concepts of Ebola prevention with these cold, warm, hot zones. And so here's just an example of one, you know, that, you know, was built with temporary studs, and we really worked hard to put a lot of these plastic panels in. Yeah, it was very amazing. And ICU, you know, I was just a little piece of the design process. You guys really led the way for figuring out flow in and out, things. You got creative, you bought the walkie-talkies, there were whiteboards, there was all sorts of things going on there. You know, it'll be interesting. I'm sure there's going to be a national inquiry or BC inquiry to everything we did, and there's probably going to have to be some accountability for the cost of everything we build. And I'm still confident that we did the right thing at the right time. And so that feels really good. And then, you know, then there was the whole PPE business. Now, I don't know if you all recall, I early, must have been March or April. Now I regret I didn't write down some of these dates, that N95 masks were being stolen from everywhere. We had them locked in a room in our operating room, and boxes were being stolen. There were people selling them from back of cars next to St. Paul's Hospital that, you know, you could go on Facebook Marketplace, N95 masks were being stolen, and that was so sad. So then we were quickly, you know, having to, so then remember we pulled them all out of all the storage rooms, and they were locked cabinets and behind Lynette's desk, and Jackson's, you could barely sit down. They were those N95 masks, where to keep them all safely. And we also did you can see a bit in the picture, people using the respirators, which is something that's usually used more in industry, but we, you know, nobody knew which way the marketplace was going to go because, too, all our masks were coming out of China, and China had to shut down. So another, you know, behind the scenes that Vancouver Coastal Health then started collecting all the used N95 masks and quickly set up a PPE testing lab here, and were prepared to reuse those masks if after they had been sterilized in the event that we got even more of a shortage. But that was like outside the box crazy, and we were the only, I think the only place in North America that was thinking of that. So sometimes when people wonder, well, you know, where was some of the infection control team? Well, they were frantically trying to set up a PPE testing lab to make sure there'd be enough N95 masks. And the other thing, I love this picture, and thanks to Mary for letting me use it. I don't know who put up this big mirror. It just appeared in the PPE donning area in ICU. And I think there were little things like that that were just brilliant to do, which, you know, isn't an infection control manual. But that way people could really stand there a moment, check their PPE. You know, we had done the, you know, make sure you turn to somebody else, have them double check. But these mirrors that someone else, not me, brought in, I think were a really great way. We were trying to do, the whole focus was on saving employees. It was a real people first mandate. So yeah, just you know, it's funny for me reflecting back on some of these. The other thing we brought in was some of this novel technology, and ICU staff, I don't even know if you noticed it there, but that's where Vancouver Coastal Health was pretty innovative and pretty flexible with the money. So these are aseptic wall-mounted UVC ultraviolet light devices that can disinfect enclosed spaces, and they're triggered, so they're mounted, and when they have a sensor, so when there's nobody in the room, no movement in the room, it'll start this disinfection cycle, which goes for about 5 minutes. And so we put that in the CSICU soiled utility decontamination area. But, these were like, we had to go shopping very quickly, get them here, get FMO to agree to install them. And I'm still quite proud that turned out. And then another example was these clean slate units, which was, again, another, and I give all credit to my boss, Dr. Titus Wong, this another UBC disinfection box. So the idea is you still clean and disinfect. So you wipe down your cell phone or your stethoscope, or people are putting in all sorts of creative things, and then it goes in the clean slate. When you put the lid down, it actually, that little blue light says wash your hands. So the idea is, then wash your hands. Takes 20 seconds, you open it up, and your stuff has been cleaned and disinfected. And it was a big comfort thing. Like, I think people, we were trying. We were trying to give that extra support and use some of the modern technology to support staff. So switching away from the technology, I think when I think back to those catchphrases, and none of us had heard the word "be kind, be calm, be safe," and I give all credit to Dr. Bonnie Henry. I know, I don't think I can use the word "dig deep" again, because that seems to have been one of the catchphrases that was a lot of the pandemic, and it was like, dig deep for every wave, and then the wave would sort of go, and then it would come back, and oh my goodness, we got to dig deep again for the next wave. This whole idea of socializing new ideas, okay, we might be going to, like, Bonnie was phenomenal. We were always listening to her on the news and then thinking, so what political statement will come next? Because she was very good at giving a hint a week or two before, and then it would become policy. So, how she would socialize things. Social distancing, that was like, have we ever done that in our lifetime? And I hope we never have to do it again. And remember all the stickers on the floor and trying to do the dance, not standing too close to each other. And now, coming out of the pandemic, how do you socialize, or how do you, the whole concept now of just personal space is okay. Thanks people in the grocery line, just give me a little bit of room here. I'm not going to go into all the nightmare AGMP talks and politics and science about, what's droplet spread versus airborne spread. You could have a whole nother talk on that. That is still very complicated, and I would say that the jury is still out 50-50. We're fortunate VGH ICU has always gone as far as to the higher standard concerned about airborne spread. So you guys have, for years, already worn N95 masks, much more than other ICUs. On the units, we continued with droplet and contact spread precautions, unless they were actually doing an AGMP. And those first 6 months, if every kind of AGMP or non-AGMP was asked of infection control, and very hard to define some of these by droplets and millimoles and what have you. So those were hard times. Was that a catchphrase or just difficult times? And yes, of course, the whole, even now in your personal life, do you need a cloth mask? Do you need a medical grade mask? Do you need the fake N95 mask? I think the jury is still out on some of that. I would say masks work. We do know that. Which is the best all the time? We'll leave that up in the air for now. And then, on that, well, I guess I spoke ahead of myself. There was some mask drama, wasn't there? That whole time we were short on masks. Oh my goodness, those were scary days for me. And then I just threw in this cartoon because who would have thought masking would become such a political issue, such a social issue? It was such a polarizing issue. And I still sort of laugh because when I look at ICU nurses on a 12-hour shift, they may be wearing a mask for 10 hours of the 12-hour shift. And we've got so many people out in the public complaining about wearing one when they're going to the grocery store or something. So, but I think that's been a really tough year, and we have to keep acknowledging that. Which leads me right, stressors on our mental health. I think, there was a lot of different trust issues, and also for infection control people, we had to tease out some of the literature. We would get conflicting reports from, never trust all the politicians. Who do you listen to? So we were focused on Public Health Agency of Canada. We follow the U.S. Center for Disease Control. Then we go through the provincial health officer, which would be Dr. Bonnie Henry. Then we had our local medical health officers weighing in. Then I had my boss, the hospital infection control officers or your own health authority leadership. And not everybody always agreed. So, I think I'm really, again, proud of BC that I really think they left a lot of the politics behind and they let Bonnie lead. And she had the support of Adrian Dix. And it didn't get political like we saw in Alberta or Ontario. And I know the social media, oh my goodness, I think I would never have imagined how much social media, things like Facebook, could influence a pandemic, and how hard personally that has been for many of us, myself included, weighing out, who to believe, who's posting what's all going on. And I know we kept just saying, we'll wait for Bonnie, we'll wait for Bonnie. And when Bonnie said, after a while I said, if Bonnie told me to stand on my head, I would have stood on my head. She was a leader. She had the expert consultants, she had the epidemiologists, she had the world information, and it was just follow Bonnie. So I think, I'm going to try and conclude now. I think it's really important right now to acknowledge where we are at, sort of now in these different phases of the pandemic, because, we could talk for hours. The vaccine issue was very divisive. I remember the very beginning of the pandemic, I was like, we'll never get a vaccine. They can't make vaccines that quick. And they did. Okay. And then it was very divisive. Who got the first vaccines, right? Was it the long-term care facilities? Was it the ICU nurses? Was it the care aides in a care home? That sort of thing. So the vaccine, and then in our personal lives, whether we got it, whether our family members would get it, whether our family members would say, oh, that's ridiculous. So the vaccine, which should have been like just, thank you so much moment, sort of on reflection, shocking how difficult that was. And I think I remember talking with ICU nurses, there was the work side of things. And, for me, wow, I worked a ton of overtime. But there was the personal side in our lives. And I felt most sorry for staff who had young children, because it was one thing dealing with this at work. It was another thing if you were trying to figure out the school system and could your kids go, could they not, were they exposed, were they not? I was like, kudos to everyone with kids in school and trying to sort that out. And then I think, at this stage too, we have to it's time now to reevaluate what are we doing for PPE? How long do we need it to isolate patients? Vaccination status. For a while, we thought that was going to be the end all, and then, then we got a different strain, and it was like, oh, maybe the vaccine isn't as great as we thought. So, it's really trying to learn from that now and tease out things. And I think, there's this catchphrase about hypervigilance, and, when, Amanda, I think you were talking about trauma, how, if we get another wave this fall and we have to dig deep again, it's really thinking that through, because it's been a long time of hypervigilance and trying to figure out, what may come next. So closing reflections for all of you out there who are, in different facilities, I'd say connect with your local ICP. I think to me, this was all about teamwork. I'm privileged. I've been invited to ICU team meetings, quality meetings, leadership meetings. Sometimes you would even invite me for lunch. It's all about working together, all those expressions about teamwork. And I think it's not only now to focus on COVID-19, but also, we still have things like Clostridium difficile, MRSA, and the next, sort of emerging antibiotic-resistant organism would be CPO. And, I think the whole idea of emergency preparedness for things like Ebola or a different pandemic, I think this has really brought it to the forefront. And so I have to say, yes, my hero is Bonnie Henry. I was so happy that she came to see you guys in ICU. This woman had the whole province, from mining camps, after her for information, the teachers union, parents, everybody. And I was so sad I missed that day. But to me, yeah, because it wasn't about me, it was about you guys in ICU. But I do have to thank ICU, and I'm just going to touch on this because last year, in the midst of this, I was nominated to be a frontline hero of infection control. And I think my comments in there say it had nothing to do with me. It's all about the team I work with, and really, it was all about Bonnie Henry's leadership. So I hope I've left you for a couple of minutes for questions, and if not, I'm very open to anybody reaching out behind the scenes to me. If you're having trouble engaging with your infection control team or something, please let me know, and I'll gladly try and help you with that. So thank you very much for inviting me, and you're my heroes.
Awesome, Rita. Thank you so much. Your presentation was amazing. Anybody have any questions?
I think it was such a nice walk down memory lane. I mean, not that we ever want to walk down this memory lane, but it was nice because I think everything you described, it was really reflected in our experiences here as well at St. Paul's and MSJ. The one question I have is about the wall-mounted UV disinfectors. Where did you implement them? When do they turn on and off, and how did you know? And what impact have you done any evaluation about what impact it had on infection control effectiveness?
Sure. So I can't speak about it for COVID. You know, it was I'd say a nicety that we tried, you know, an additional comfort. But a few years ago, we did a study in the bone marrow transplant unit using multiple engineering approaches to see if you could reduce the transmission of infections there. And it was just a pilot to see if there was anything that would maybe work. So we used everything from UV disinfection to surfaces wrapped in copper. Like copper is the new and up and coming antimicrobial surface. So we put these copper surfaces like on everything from toilet seats to handrails to I think some of the IV poles. We even used a copper impregnated paint in the room, and the pilot then looked at bone marrow transplant patients whose, you know, normal flora was sort of wiped out, and then how the flora came back. And it was done in conjunction with swabbing nurses' hands to see, you know, what the relationship was there. And, you know, all that data is still being collated. But the UV disinfection lights we've also used in places like Lionsgate in the bathrooms that are 4-people bathrooms, and trying to reduce the rates of C. difficile on those kind of medical wards where, you know, you've got one toilet for 8 people and they're going in and out. So that way, at least it disinfects the bathroom while there's nobody in the room.
And thank you so much for your presentation and for everything. Honestly, we would not have survived this. You know, for those of you who don't work with Rita, she is just an incredible force and deserving of keeping helping keep our sanity over the last.
And I'd like to take a moment to thank so people like who I saw in here: Sarah, Lana, Jackson, Dara, I miss you, Lynette, Jeff, Tammy, Nicole, Simi, for, you know, we were a team, we were in the thick and thin of it, and there were many times I would go to you guys and I could sit there and drop some swear words, and I was in a safe zone. So the love was very mutual, and I thank you all very much.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.